Grasping the differences between bipolar I and bipolar II disorder is crucial as you prepare for your licensing exam. These two conditions share some overlapping symptoms, but their diagnostic criteria and treatment approaches are distinct. Misunderstanding these differences can lead to errors in clinical judgment and affect the quality of care you provide. The exam often tests your ability to recognize subtle distinctions, so a clear understanding will help you answer questions accurately and confidently. By setting a solid foundation now, you'll be better equipped to navigate complex scenarios and avoid common pitfalls that can arise from confusion between the two disorders. To accurately identify bipolar I disorder, it's essential to understand the DSM criteria, with a particular focus on manic episodes. These episodes typically last at least 1 week or require hospitalization if they're severe. Symptoms may include an abnormally elevated mood, increased energy, reduced need for sleep, rapid speech, and impulsive behavior. The severity of these symptoms often leads to noticeable disruptions in a person's ability to function at work or maintain healthy relationships. When assessing a client, look for these patterns and consider how their mood changes impact daily life. Recognizing these signs is crucial for proper diagnosis and effective support. Bipolar II disorder is characterized by a pattern of alternating hypomanic and major depressive episodes. Unlike bipolar I, individuals with bipolar II never experience a full manic episode. Hypomania involves elevated mood, increased energy, and activity, but these symptoms are less severe than mania and do not cause significant impairment or require hospitalization. Recognizing the distinction is important. Hypomania may present as increased productivity or sociability, but it lacks the extreme behaviors seen in mania, such as risky spending or grandiosity. For exam purposes, remember that the absence of true mania is what sets bipolar II apart. Major depressive episodes in bipolar II can be severe and prolonged, often leading to significant distress. Spotting these patterns is crucial for accurate diagnosis. Bipolar I and II share several key features that can significantly impact a person's mood, energy levels, and ability to function day to day. Both types involve episodes of depression that may look quite similar, making it challenging to distinguish between them at first glance. Symptoms such as changes in sleep, appetite, and motivation often overlap. Because of these similarities, it's not uncommon for clinicians or clients to confuse the two if the CISU are not careful. Recognizing these shared patterns is an important step in understanding the nuances of bipolar disorders. Now, let's dive into the key differences between bipolar I and bipolar II. In bipolar I, mania is much more severe. It can last for at least a week and often requires hospitalization due to risky behaviors or loss of touch with reality. In contrast, bipolar II features hypomania, which is less intense and doesn't usually disrupt daily life to the same extent, but is paired with longer periods of depression. For example, someone with bipolar I might go days without sleep, make impulsive decisions, and need medical intervention, while someone with bipolar II may feel unusually energetic or productive, but still maintain control, followed by extended episodes of low mood. Understanding these distinctions is crucial for recognizing symptoms and providing appropriate support. Sarah, a marketing executive, began exhibiting dramatic changes in her behavior. Initially, she struggled with severe insomnia and started sending impulsive, erratic emails to colleagues. As her condition progressed, Sarah became increasingly energetic and grandiose, culminating in an episode where she climbed onto her office roof, convinced she was destined to make a global impact. These escalating symptoms, reduced need for sleep, impulsivity, and delusions of grandeur, are hallmark signs of a manic episode. Recognizing such patterns is crucial for identifying bipolar I disorder. By examining Sarah's journey, we can better understand how mania develops and what warning signs to look for in diagnosis. Sarah's case is a clear example of bipolar I disorder rather than bipolar II. The defining factor is her manic episode, which was not only severe but also lasted for an extended period and required hospitalization. These details are crucial because bipolar I is characterized by at least one full manic episode, often accompanied by psychotic features and significant impairment in daily functioning. In contrast, bipolar II involves hypomanic episodes that are less intense and do not lead to hospitalization or major disruption. Remember, the presence of psychosis and marked impairment are key indicators that set bipolar I apart. These are the details you should focus on for your exam. Michael is a dedicated teacher whose life is marked by dramatic shifts in mood and energy. For several days at a time, he feels exceptionally productive and sociable, taking on extra projects at work and enthusiastically engaging with his students and colleagues. However, these bursts of activity are soon followed by periods of deep depression, where even routine tasks become overwhelming. At home, his family notices the contrast between his energetic, upbeat demeanor and the times when he withdraws and struggles to participate in daily life. These patterns illustrate the hypomanic episodes and depressive cycles characteristic of bipolar II disorder. Michael's experiences provide a clear example of how this condition can affect both professional responsibilities and personal relationships. Michael's diagnosis is bipolar II, rather than bipolar I, because his elevated moods never reach the intensity of full mania. In bipolar II, individuals experience hypomanic episodes which are noticeable but not severe enough to cause major disruptions or require hospitalization. Unlike bipolar I, there are no periods of uncontrollable excitement or risky behavior that lead to significant consequences. It's important to recognize that bipolar II still involves depressive episodes, but the up phases are less extreme. For exam purposes, remember that the key difference is the absence of full mania in bipolar II. When assessing clients, watch for patterns of mood elevation that are noticeable but not life-altering, alongside episodes of depression.